So hey guys, my name is Rishabh Singh, a first year medical student from Eastern Medical College and Hospital, Comella. Welcome to my channel. If you are new here, so please go and subscribe to my YouTube channel. I try to provide you some educational video related to MBBS. I hope you will gain or acquire something new at the end of it. If you like, don't forget to subscribe, like and comment below. Guys, welcome to my YouTube channel. Today's topic is gallbladder anatomy. In this video, I'm going to discuss about the gross anatomy of gallbladder. So, gallbladder is the offshoot of the GI tract. Its capacity is 30 to 50 ml. Function of gallbladder. Now we know that liver produces bile, but it is stored in a pouch-like structure which is called gallbladder. So it stored the bile, and it also concentrate the bile 10 times than the liver do. Also reduces the alkaline nature of the liver bile, because as we know bile is alkaline in nature, so it reduces that property. Now parts of gallbladder: fundus, body and neck. And vertebral level is lumbar 1 or the tip of 9th costal cartilage. So this is the diagram in which we can see the different parts of gallbladder along with various ducts. It is basically a diagram of components of extrabiliary apparatus. You can see here it is gallbladder with fundus, body, neck. This is the right and left hepatic duct from liver, which combines to form common hepatic duct. The duct which goes to the gallbladder called cystic duct, it combines with common hepatic duct to form bile duct. And there is also a presence of a Hartmann's pouch in the gallbladder. So there is a sphincter of Colic or Boideman which is present in the bile duct, which guard the opening and closing of bile duct. And here you can see the main pancreatic duct which have a sphincter pancreatus which guard the opening and closing of the pancreatic duct. And you can see here the sphincter of OD, and which regulates the opening and closing of all the components in the duodenum. And here you can see major duodenal papilla, minor duodenal papilla, accessory pancreatic duct open to minor duodenal papilla, and this main part open into major duodenal papilla. And this is basically the hepatopancreatic ampulla, or basically ampulla of Vater, which opens into major duodenal papilla of the duodenum. Now we will talk about the biliary apparatus. It is intrahepatic part, that is bile canaliculi, canals of Henning's, bile ductals, right and left hepatic duct. Extrahepatic part includes common hepatic duct, gallbladder, cystic duct and common bile duct or bile duct. So the dimensions of gallbladder are length 10 cm, width 3 cm. Now we will see the gallbladder peritoneal relation. Fundus is covered by peritoneum on its all the sides from inferior border. Its extent is called fundus. Superior surface of body and neck is attached with the liver, and it is devoid of peritoneum. Under surface of the body and neck is covered by the peritoneum. So this is the relation of gallbladder with the peritoneum. Where does bile duct open? Bile duct open into major duodenal papilla, which is 10 cm distance to the pylorus. Now what is lining epithelium of gallbladder? It is simple columnar epithelium. Artery supply by cystic artery, venous drainage by cystic vein, and development of gallbladder occur from foregut. Artery of foregut: celiac trunk, which form common hepatic artery, right branch and left branch. So cystic artery will supply the gallbladder, which is the right branch of the common hepatic artery. It have superficial and deep branches. Cystic vein open to portal vein, which is its tributary. Now coming to Callet's triangle or cystohepatic triangle of Callet. Boundaries of Callet triangle are cystic duct, common hepatic duct, under surface of liver. Contents of common hepatic duct, it's cystic artery. Contents of Callet's triangle or cystohepatic triangle of Callet, right hepatic artery and cystic lymph node. Now coming to the various parts or layers of the gallbladder. So gallbladder has three layers: mucosa, fibromuscular layer and serosa. Usually mucosa have lining epithelium, lamina propria and muscularis mucosa. But in case of gallbladder, lining epithelium, as we all know, it is simple columnar epithelium. Lamina propria is also present, but muscularis mucosa is absent. Fibromuscular layer, in which it is present but submucosa is absent, and then serosa. Muscularis mucosa not present because it separates mucosa from submucosa, so when submucosa is absent of muscularis mucosa is also absent. In microscopic, mucosa membrane is loosely connected with fibrous layers and it is elevated into minute rugae which gives to honeycomb appearance to it. So basically in histological structure we will see the honeycomb appearance. Here you can see the diagram of cystohepatic triangle of Callet, in which liver, you can see the liver, you can see the cystic artery, cystic duct, bile duct, cystic lymph nodes, common hepatic duct, left hepatic artery and right hepatic artery. But the contents of Callet's triangle is right hepatic artery, which is present here. You can see a triangle here. This is the Callet's triangle, and you can also see cystic lymph node is present here. So right hepatic artery and cystic lymph node are the content of Callet triangle or cystohepatic triangle of Callet. Mucosa is thrown into primary, secondary and tertiary folds, so that's why in gallbladder it appears as honeycomb structure. Cells of gallbladder are tall columnar cells, basal cell and pencil cells. And now the parts and relation. Fundus is expanded blind end of the organ. It completely surrounds peritoneum. Anterior relation, anterior abdominal wall. Posterior relation, transverse colon. It is continuous with the body of gallbladder. Now coming to body. Directed upwards, backward to the left to join the neck at the right end of porta hepatis. Its upper surface relation is with liver, where it is devoid of peritoneum, and under surface is covered by peritoneum and related to second part of duodenum. Now coming to neck. Neck is the narrow upper end of gallbladder lying near the end of porta hepatis, which join with the cystic duct, and this junction is marked by a constriction. It is also attached to the liver by loose areolar tissue in which cystic artery is embedded. It is also related inferiorly with the first part of the duodenum. Its posterior medial walls show a pouch-like dilatation which called Hartmann pouch, directed downward and backward. The gallstone lodged in this pouch may cause adhesion with the first part of duodenum and may perforate it. The pouch is Hartmann pouch. The neck turns sharply downwards to become continuous with the cystic duct. As you can see in the diagram, this is liver, this is first part of duodenum, which is related with the Hartmann's pouch. This is Hartmann's pouch. So whenever there is gallstone, so it can perforate it can cause adhesion and with the first part of duodenum, and then it can perforate it. So this is the neck, this is the body, the fundus part of gallbladder, this is common hepatic duct, cystic duct, and it is the head of pancreas, it is transverse colon. This diagram represents the sagittal section through the gallbladder fossa. Now coming to lymphatic drainage. Lymph vessels from gallbladder drain into cystic lymph node of land located in Callet's triangle and node along upper part of bile duct node at the interior border of epiploic foramen, which finally drains into celiac group of lymph node. So these two group of the lymph nodes basically drain the lymph. Few lymph vessels from the upper surface of gallbladder directly communicate with the subscapular lymph vessels of the liver. So few vessels also communicate with subscapular lymph vessels of the liver. Cystic nose is constantly enlarged in cholecystitis, which is inflammation of the gallbladder. It is a disease condition in which gallbladder is inflamed. It occurs in acute and chronic condition. Nerve supply. Sympathetic fiber from thoracic 7 to thoracic 9 segment of nerve, and parasympathetic fiber from right vagus nerve and left vagus nerve, and also through fiber of right phrenic nerve. Coming to cystic duct, it is 3 to 5 centimeter long, run backward downward from the neck of the gallbladder to run in the lesser momentum with the common hepatic and join it at an angle to form bile duct. As you can see in the figure, it joins the bile duct. It forms to join a bile duct. The mucous membrane lining of interior of cystic duct is thrown in a series of concentric fold 5 to 10 in number, which forms the spiral valve of Hester. Now the valve of Hester opens so that bile can pass through in both in and out of gallbladder. So this is the valve of Hester, which allow the movement of bile through the gallbladder. The flow of bile is augmented by the contraction of the gallbladder, coordinated by the relaxation of the sphincter of common bile duct under influence of cholecystokinin, a hormone which is released by adrenal mucosa on the fatty meals. Now coming to bile duct or common bile duct. It is 7.5 centimeter long and it is having the diameter of 6 mm, which do not exceed 8 mm. Parts of bile duct are supraduodenal part, retroduodenal part, infraduodenal part or pancreatic part, or intraduodenal part. As you can see in the diagram, it is supraduodenal part, it is retroduodenal part, it is infraduodenal part, and it is intraduodenal part. These all are the parts of bile duct. You can also see the main pancreatic duct and pancreas in the diagram. Now coming to supraduodenal part. About 2.5 centimeter, most accessible part of bile duct for the surgery. So supraduodenal part is most accessible part. Retroduodenal part descends behind first part of duodenum with the gastroduodenal artery on the left and inferior vena cava on the posterior aspect. Intraduodenal part. The main pancreatic duct also enter the duodenum at the same site. Two ducts obliquely run in the wall of duodenum, unite to form an expansion called ampulla of Vater or hepatopancreatic ampulla, which bulges in the mucosal membrane of duodenum inwards, forming a major duodenal papilla. So that part is called as intraduodenal part. Now coming to the sphincter or the terminal part of bile and pancreatic duct and ampulla, which is basically surrounded by a smooth muscle sphincter. Sphincter of Colic or Boydman is the sphincter on the bile duct. Sphincter of Pancreaticus, it is sphincter around the pancreatic duct. Sphincter ampulla of OD is sphincter around the ampulla. The sphincter remains closed until the gastric contents enter the duodenum, stimulating its mucosa to release a hormone called cholecystokinin. This hormone, in addition to cause the contraction of gallbladder, release this sphincter, allowing the bile and pancreatic secretion to enter in the duodenum. Coming to cholecystitis, it is an inflammation of the gallbladder is called cholecystitis. It may be acute, chronic. In this condition, cystic node is enlarged. Acute cholecystitis occur in adult women. Symptoms usually pain occurs in hypochondrium region of the abdomen or the shoulder region or inferior angle of the right scapula, and blotting, nausea, vomiting also occur. In whole body chills, fever and sweating occur. It is a system which get worsen on the fatty meals will release cholecystokinin, which will release the bile from the gallbladder by contraction. So it will contract the gallbladder and worsen the condition of cholecystitis. So chronic cholecystitis led to the formation of stone in the gallbladder, which occur in fatile flatus female of the 40, which is represented by 5F. Now coming to biliary colic. It is usually caused by the spasm of smooth muscle of the gallbladder wall in an attempt to expel the gallstone. This is called biliary colic, and basically obstruction of common bile duct. The obstruction of common bile duct usually occur due to gallstone, pancreatic carcinoma, or enlarged neoplastic hepatic lymph node. It causes obstruction to bile flow, which led to the jaundice. Now we will see the imaging of the biliary tract. Cholecystography. Gallbladder is not opaque to X-ray, but when certain radio-opaque dyes are given by either mouth or intravenous injection, they are excreted by the liver from the blood into the bile and reach the gallbladder. In the gallbladder, the dye is concentrated and thus the gallbladder become opaque to X-ray. So this is the method by which we can see the gallbladder. Coming to ultrasound, the ultrasonography is a non-invasive imaging technique to visualize the gallbladder and other components of the biliary apparatus. The technique has largely replaced the cholecystography. So ultrasound basically replaced cholecystography. Now, what is endoscopy retrograde cholangopancreatography (ERCP)? In this technique, under direct vision through a fiber optic endoscope, a catheter is inserted into the hepatopancreatic ampulla and radio-opaque contracts. The medium is injected and bile and pancreatic ducts are visualized. If ERCP fails, the biliary tract is visualized by a radiological technique called percutaneous transhepatic cholangiography, PTSC or PTC. As you can see in the diagram, ERCP is done for demonstrating multiple small caniculi within the gallbladder and common bile duct. Here you can see the common bile duct in which the stone is seen in common bile duct. So by this we can diagnose a disorder related to gallbladder. So this completes our topic on gallbladder. Hope you like this video. If you like this video, don't forget to like, comment, subscribe to my YouTube channel, which is MBBS Studies with Rishabh Singh. Thank you.